Good morning. My name is Dulce Brito. I'm professor of cardiology at Lisbon University, and it is my honor to share this session on amyloidosis, namely cardiomyopathy related to amyloid heart disease. I think that this disease it's so difficult sometimes to manage that we must to promote patient-centered care. And with this discussion that we have, I think that we may ensure an early diagnosis and a best management of this condition. The session will explore how patients can be better involved too in ATTR cardiomyopathy advances regarding not only drug development, but clinical care and health policy. This panel will discuss how people living with this disease can be really involved in raising awareness of the condition and the importance also of psychological support in maximizing the quality of life of those living with ATTR cardiomyopathy. We will have three speakers in this session: Professor Nikki Bart at my side from the Victor Chang Cardiac Research Institute, Australia, Mr. David Gregory from Amyloidosis Alliance, and Dr. Chirusha Lane, registered nurse and ATTR cardiomyopathy patient advocate. So I will address some questions to each of our speakers, but after that, there will be a 20-minute open discussion with the audience. So please, at that time, feel free to participate. To note that this Heart Cafe session has been made possible by the support of three important sponsors: AstraZeneca, Pfizer, and Alnylam. Thank you for the important partnership. So, Professor Nikki Bart, our first question is, could you give us an overview of what ATTR cardiomyopathy is, who its affects, and how it's usually diagnosed?
Thanks, Dulce. So amyloidosis is a broad umbrella term for proteins which misfold and deposit as fibrils. So you've got two main types of amyloidosis which affect the heart. You've got ATTR or transthyretin and AL or amyloid light chain. Today we're going to speak specifically about ATTR. So ATTR is divided into two different subgroups. The first is wild type, and the second is variant. Now, when these fibrils deposit, it's a truly multi-system disease. So fibrils, misfolded proteins deposit in the heart. When they deposit in the heart, they cause heart failure. And this can be across the spectrum of ejection fraction. So you can get heart failure with preserved ejection fraction. You can get, in more advanced disease, heart failure with reduced ejection fraction. You can get amyloidosis in the conduction system, causing both atrial fibrillation and other atrial arrhythmias, as well as ventricular arrhythmias, and it can deposit in the valves. Importantly, amyloidosis, ATTR amyloidosis, can also affect other systems. So it can affect the kidneys, it can affect the peripheral nerves, it can affect the autonomic nervous system, which can lead to autonomic instability, and also the gastrointestinal system, which can lead to early satiety, constipation, and a number of other poor nutrition. So when we think about ATTR cardiomyopathy, we also have to think about this as a truly multi-system disease, and we have to very much approach it from a kind of multi-system perspective. So how do we work up and how do we diagnose amyloidosis, ATTR amyloidosis cardiomyopathy? The first thing to say is that we need to think about the clinical symptoms. So what are the red flags? So you've got to think about heart failure. And when you think heart failure with preserved ejection fraction, with increased LV wall thickness, there was a study out of the Mayo Clinic that showed about 6% of those patients actually have cardiac amyloidosis. When you look at plus other red flags, so low flow, low gradient stenosis, then the proportion of patients that actually have ATTR are much higher. We've also got to think about red flags that are orthopedic manifestations like biceps tendon rupture, carpal tunnel syndrome, lumbar canal stenosis, and that combined with heart failure is a really big alarm bell for me that this might be an ATTR cardiomyopathy. Finally, persistent troponemia or persistently elevated BNP, these are other things to think about. Once we've got clinical symptoms, we can think about investigations. So your basic investigations like 12-lead electrocardiogram and an echocardiogram. And then really the hallmark for diagnosis is the simultaneous bone scintigraphy plus blood and urine for EPG, IEPG, and serum-free light chains. And what has revolutionized this space is that now we can diagnose ATTR cardiomyopathy non-invasively if you meet certain criteria. And if not, then you've got to go and have an invasive diagnosis. That might look like the heart biopsy. It might look like a surrogate site biopsy. And to have this multidisciplinary team discussion to have the diagnosis. So I suppose the key message from this is that amyloidosis is much more common than we think. The workup has to be multi-system and involve multimodality, and we have to have a higher index of suspicion.
Thank you, Nikki. However, I think that there are a lot of challenges in diagnosing this complex disease. Can you point some of these challenges in the clinical practice?
Absolutely, Dulce. So the first thing to say is that only about 6 years ago, we didn't have treatment. You know, we saw in the hotline session today that it was only, within the last decade that tafamidis came out as a hotline session, and today we saw vutrisiran as a hotline session. So the space has rapidly changed. And so a big challenge is raising awareness that we have this disease-modifying therapy. A lot of general practitioners in their clinical career might not have had this disease-modifying therapy, and therefore our awareness is low. And we are understanding that our diagnosis of amyloidosis is very much the tip of the iceberg. There is a lot that we are missing. And so I think a big challenge is being able to increase awareness and increase education. The other big challenge is being able to get patients to multidisciplinary centres of excellence because of wait lists, because now we've got a lot more patients being diagnosed, which is a good thing, but streamlining those services and then getting patients access to treatment because a lot of the drug therapy is incredibly expensive.
Oh, that would be quite a challenge. How do you think that awareness can be increased or to best communicate it in clinical practice terms to medical doctors, namely at the level of primary care?
Yeah, so I think it starts, we've got to raise awareness at the level of the medical student, at the level of the nursing student, up to primary care doctors, general physicians, internists, cardiologists, and then specialist cardiologists. And I think we've gone a long way with the World Heart Federation consensus document to say this is how we should, this is the way of excellence of being able to diagnose and raise awareness. Things like this Heart Cafe, we're able to share some of the important information. And I think getting into different practices at every different level to raise awareness, to educate, and then to streamline treatment.
Okay, thank you. And now, David, you occupy in this round table or in this discussion a central position in every way. In every way. So my first question is, as a patient advocate for ATTR cardiomyopathy, how do you think patients could be more involved or engaged with caring for or providing support to patients?
Good, thank you for that. Just to say who I am, I'm David Gregory. I'm one of the directors of the Amyloid Alliance, which is the organisation that supports countries throughout the world. It's about 28 countries that we support. So we focus on them to get things that will take them forward. I'm also a patient with hereditary amyloidosis. I guess I'm also a product of, because of the treatments I've had, I've been diagnosed 7 years, a product of someone who's got it at an early stage. So the actual gene that you talked about a minute ago, is really slowed up within me. So that's a real positive start with that. I've got a sister who passed away with it, so I saw the other extreme. You say 6 years ago, that's when she passed, and there was nothing, or very little, I should say, that would actually slow down the gene protein. So I guess I am a product of being involved with getting into a space that supports people with ATTR amyloidosis. I think it's fair to say, even now, people go on a search engine, Google, to find out about amyloidosis, and the data is really old and out of date, and also very complex. So the first element that we ask for is that support from the hospital to give them that first insight to it. And then the second part is, as a patient organisation, we're there to pick up and possibly put it into normal words from the sometimes complex first data that they get. So, one of the things we encourage with the patients is that they build up a really good knowledge of the disease, because they're going to go to places, GPs or other specialists, and that the people aren't going to know what amyloidosis is. So we really do encourage, to take personal responsibility for it and really get to be an expert, because it is a subject that's, confound the experts in other fields.
People living with such a chronic disease, and in any way, in several ways, all of us live with specific or in specific and chronic conditions. But regarding amyloidosis, ATTR-CM, patients can feel very isolated sometimes. How do you think patient associations can deal with this and help on this? What's your feeling in practical terms?
Yeah, it is a real, you hit it on the head, actually. It's a real challenge for people to get information about it, and they're confounded by what it is. Sometimes they go down different specialists, and it becomes a real problem because that particular specialist don't pick up. So diagnosis is a massive problem.
And do you think that to share experiences will help?
Yeah, absolutely. Telling their stories, and the pathway that they've gone really does help to make it more alive. Just reading something about it.
That's very important.
Yeah.
Do you know that I heard something from the president of the Amyloidosis Association from another country last year, that is that he's also a patient, and he told me personally that doctors and patients feel different regarding this disease, perhaps other diseases, feel very different. So do you feel that also?
Yeah, very much so, especially because you go to a non-specialist and they don't know what the disease is. They're looking on the search engine as well to check to see what the what it is. Yeah, it's a big challenge.
A timely diagnosis and treatment of ATTR cardiomyopathy remains also a challenge. What are some of the Amyloidosis Alliance upcoming plans or campaigns as a patient advocacy group? What do you think it must be planned?
Yeah, so as I said, the Amyloidosis Alliance helps organisations throughout the world. So we bring best practice to those different countries and help influence them to develop an understanding of what other people are doing, because there's some great things out there. Some of the organisations are quite big charities or organisations. Some of them are startup ones. So it's one of the things we encourage is, like this year, Belgium have just started their first organisation, and we've supported that. And that's really exciting because before that, they didn't have anything within a country that actually is quite sophisticated and forward thinking with that. So over the last 3 years, we've also have a 26th of October is our amyloidosis day. And although it's kind of one day, we really do focus every year to help all those organisations around with materials to help them rejuvenate themselves every year, but also bring a different slant on the challenge of amyloidosis and the good things that are being developed out there as well. And one of the other elements is that when we spoke to those countries, there's some countries that have very little treatment, and they really don't have anything to support them. And that's something that we are, when you speak to someone from a particular country, it's quite emotional what they don't have and how it compares so well with other, countries that have more facilities and money, if you know what I mean.
Oh, it's almost a full-time job.
Yeah, yes. A good job though. I do enjoy it. And that's great.
Thank you. Tirucha, how has the amyloidosis landscape changed over the past few years in terms of medical advancements, treatments, or awareness? What do you think about that?
I think the landscape today is just completely different from the disease area that I joined in 2008. So I started my career in amyloidosis in 2008, and speaking specifically about ATTR amyloidosis, those conversations with patients and their families in clinic were, there were two types of conversation. And David, you've testified to this. It was either your echocardiogram is exactly the same as it was a year ago, and we'll see you in another year, or your echocardiograms got worse, and perhaps it's time to start, getting your affairs in order. So it was really, the options for patients and their families were just so limited, and there was so little that as healthcare professionals we could offer. And now it's, as Nikki and David have both highlighted, and the presentation from Prof. Fontana earlier, it's a completely different space. The conversations are so much more positive. There are treatments already available. There are more innovative treatments in development, and most importantly, people have hope. Patients have hope that they could live longer and live better with this condition. And I have to actually caveat, as David highlighted, that we're talking about the developing world here. There are so many other parts of the world, Africa, parts of Asia, South America, where patients are still in the situation that we were in back in the 1990s and the early 2000s. So it's wonderful, and we can celebrate how far we've come in the developing world, but we mustn't forget that there are huge numbers of patients outside in the developing world that aren't experiencing the same hope.
In your point of view, as a registered nurse and have central role in dealing with this kind of disease and with patients, which do you think are the main unmet needs regarding the care of patients with amyloidosis?
We've talked about how we now have non-invasive diagnostic techniques, and we have therapies, and this means that people are getting diagnosed earlier. We're seeing that shift already, that cardiac amyloidosis being diagnosed much earlier in the disease course, and then having treatment. And so, that's fantastic, but there are still lots of unmet needs. And in terms of diagnosis, there are still issues, because we're still, even today, describing, for example, wild type ATTR amyloidosis as a disease of elderly white men. And yes, historically it has been a disease of elderly white men, but there's no end of data, presentations, publications, which actually challenge that. For example, people are being diagnosed now in their 50s, thanks to scintigraphy and non-invasive diagnostic techniques. We know that women also get wild-type ATTR amyloidosis, but they're not being diagnosed because our echocardiogram criteria are outdated and don't factor in body surface area. And we also know that ATTR amyloidosis, wild-type ATTR amyloidosis, is not just a cardiac condition. There are multi-system effects, and many of these extracardiac manifestations like neuropathy, bowel dysfunction, they actually show up about 10 years before the cardiac manifestations. So we're still missing a lot of opportunities to diagnose people earlier and better, and certainly underserved communities like women and people with, for example, the v02 mutation are just largely invisible still. So there are still those unmet needs too.
You touched a very important point. In fact, women are underdiagnosed with ATTR and are not well represented in every registries or trials. This is a very important point to consider. And what are some of the recommendations that have been developed for people living with ATTR cardiomyopathy? Do you know that the World Heart Federation is working on a toolkit for patients with this disease? And do you think this will be a useful tool for patients? And there is already something like that?
I think that there are just so many opportunities that that are out there, and it's great to see the World Heart Federation, in addition to the guidelines for healthcare professionals, great to see that there's resources for patients as well. And I think, it's almost unbelievable that as an amyloidosis veteran, I am sitting in a mainstream congress like ESC talking about ATTR cardiomyopathy. It's crazy, because my first amyloidosis conference in Europe was, I think there were about 15 of us, in 2008. And then the amyloidosis congresses where people interested in amyloidosis go over the years has just grown so much. I think in Heidelberg, they actually had to close registration early because there were too many people registered. It was like over 2,000. But coming here into mainstream cardiology is, there are tens of thousands of people here, and that's fantastic. And I was looking actually last night at the number of presentations and sessions that have been dedicated to ATTR cardiomyopathy over the years. And it went from, I brought you the numbers. It went from, so in 2016, it was 6. In 2020, it was 45. And this year, it's nearly 200. And, and so that really demonstrates how much the community has grown. And there are lots of guidelines, lots of recommendations, lots of characterization cohorts. But the first time that patient-centric abstract appeared was only in 2023. And it was at ACNAP, which is the Association of Nurses and Allied Health Professionals. So it makes sense that nurses and allied professionals would see, this as an important topic. David, you took part in that session, and then the next year we had 4 presentations, patient-centric ones, about the actual experience of patients, so the burden of the condition on patients' lives, the financial burden, the caregiver burden. And then also, for the first time, we had a presentation on recommendations for holistic care. of ATTR amyloidosis patients. So that was the first time that there were recommendations that were outside of the traditionally medical sphere. So looking at the broader needs of the patient population. And that was presented by one of the ACNAP members as well. And so those recommendations, they do include the more medical aspects. So they include early diagnosis and access to treatment. They include recommendations for disease monitoring and coordinated care, which is very important. But they also look at maintaining quality of life, physical and mental health. So there are recommendations for example, physiotherapy, occupational therapy, psychological support, all of these other aspects of care that patients and their
all the
families
important
need.
things, all the important things.
Absolutely, yes, absolutely. And so it's really great to see that the community is now starting to look beyond the organ of the heart and look at what else patients and their families need. And actually last year at the Heart Cafe, you and David were there, I think, as well. And Prof. Fontana spoke really quite openly about her experience as a cardiologist. And she said that as a cardiologist, when she was talking to patients, she assumed that they were interested in what she was interested in, which was the echocardiogram result or the MRI result. And, and her learning curve as a physician was that, was to listen to patients and actually ask them what's important to them. And she was really surprised to find out that what they were concerned about was their mobility, so their ability to continue to walk and be independent. What was holding them back was bowel dysfunction, pain from their musculoskeletal effects of the condition. So, it is going back to your earlier question about how sometimes doctors and patients see the condition differently. We are now in this, in the sphere where physicians are recognizing that, patients value different things to promote their quality of life.
So I have some additional questions. My own doubts, Professor Nikki Butt. Why it take sometimes so long, several years, to diagnose ATTR cardiomyopathy? And what, in your opinion, may be the risks of a delayed diagnosis for patients?
Yeah, it's a fantastic question. So the first thing to say is that there is literature to show that some patients see 5 specialists before they get a diagnosis of amyloidosis. And when you think the time, the effort, the distress, the cost of seeing a specialist to then not have an accurate diagnosis, especially when you have a disease that we know is rapidly progressive without treatment, it's hard to think about, but we do know that there are huge delays. It's a big unmet need, that there are huge delays to diagnosis. So why is that? Well, I think first of all, awareness. Second of all, education. Third, we are only just getting treatment, so people feel like there's this incentive to diagnose and to upskill. I think when what you were describing of, oh, your echo's gotten worse, you've got to get your affairs in order. Well, it was very hard to want to upskill in amyloidosis when the only treatment was heart failure therapy and supportive care. Whereas now there is this real imperative, and I think that hopefully the time to diagnosis and the delays with all sorts of efforts are going to improve because we have treatment, and also we have a non-invasive diagnosis in some cases, which means that it is easier to make that diagnosis.
Patients with ATTR cardiomyopathy sometimes complain of symptoms and their signs that may mimic many other conditions, and don't you agree? And are very sometimes inspecific, as tiredness, fatigue, and it may be difficult for us to achieve a diagnosis. So we must, as you told us, to be aware that this condition exists to think on it, to diagnose it, and then to initiate treatment. Do you think, personally, that the first suspicion of ATTR cardiomyopathy with its varied symptoms that can be due to much more common conditions can arise at the primary care level of assistance? Do you think?
I hope so, and I think there's a lot we have to learn. So absolutely, 10 years before diagnosis of cardiac amyloidosis, you might have a diagnosis of carpal tunnel syndrome. Now, if we were to send off every biopsy of everyone with carpal tunnel syndrome, what does that give us in terms of follow-up? We haven't done that to a good enough degree yet. But I think there are a number of ways that we can diagnose early if we increase awareness. So, we don't typically think orthopedic or, we don't typically think carpal tunnel syndrome when we think about other heart failure conditions, but that is a fabulous red flag at the primary care level to be able to say, okay, maybe I need to do more screening, or maybe I need to follow this patient. And I think there's a lot of evolving space about early disease. We know that, now that we've got good therapy, the earlier you treat a patient, the better their outcomes. But we still don't know exactly what early disease looks like. So that's certainly an unmet need that will help from a research perspective, that then we can better understand, how to get these patients into the cardiologists appropriately, knowing that our clinics are already very busy.
And some minutes ago, you told us about atrial fibrillation, a common arrhythmia, very common in adults. That may be a red flag also to this condition. Of course, we must think very carefully what will be the next examination to ask for, but it is another matter. When you deal with a patient with atrial fibrillation, you cannot, you must think as a medical doctor, and namely at the primary care level, what will be the next exam to ask for. But as you told us, awareness is all, or almost all. If you have a common problem like atrial fibrillation or AV block in old people, you must think, this can be eventually amyloid heart disease. So disease awareness.
I was just going to add on the topic of atrial fibrillation, we haven't discussed yet, but it's very common in the general population. Yeah. And then it's extremely common and can be one of those red flags for cardiac amyloidosis. And now the guidelines, we know that you get a type of atrial myopathy with amyloidosis. And these patients are much more likely to have a stroke, which can be absolutely debilitating. Yeah. And so the guidelines now say that regardless of TRANS-VASc, all patients with ATTR cardiac amyloidosis with atrial fibrillation should be anticoagulated. And that's also something that we need to increase awareness for at the primary care level, so that these patients get the appropriate treatment, which is not kind of your standard of care in your general heart failure patient.
It's another very important point to consider. David, a burning question for you. How can the ATTR Patient Association help in any regard with the cost of targeted medications?
With what, sorry?
With the cost of specific medications designed for ATTR-CM. The association might be a pressure factor or on health policy decisions. What do you think?
You got the easy question.
I know, it's like a cost one. Bring in the farmer, I say. Yeah, not pay the cost, because I don't think we'd have quite enough money to do that. But it is, we are an organisation that has quite a lot of power. Which is why we encourage other countries to get involved with it. Particularly, in our case, we have NICE, which is the organisation that signs off all the treatments in this country, and the same have similar ones in Europe, etc. And quite often they come to the amyloidosis organisation as the key advisor on giving the patient's point across, because quite frankly, quite obviously, the nice people don't know the condition, and we're able to kind of really bring it to life through descriptions of what people go through. So getting those treatments through is something that we take very highly as one of our key targets, and we have been successful, in the last 6 years of getting the majority of them through. So I think there is countries out there that don't have any organisations yet, and they're missing an opportunity because they do need encouragement from patients to make it happen.
I think that in UK you are extremely well organized. Congratulations for that. Tirusha.
I hope it's an easier question than
Caregivers.
David's.
That wasn't on
Caregivers
my list.
have complex thoughts, and nobody talks about caregivers.
Sorry, I
Caregivers.
oh, caregivers. Yes.
They are very important. They are fundamental. They are crucial, and nobody talks on them. They deserve stronger support, in my own opinion. How can this be achieved? What do you think?
I think, I think it's in the hereditary form of the condition. We know now that family care begins at the time of diagnosis of the first patient, and so there are guidelines and recommendations on family follow-up, for example. So testing of family members, and so there is a lot. There is a fair bit published on that, but when it comes to the actual burden of the condition on the lives of caregivers, there isn't as much published there. Although in the last 5 years, that has certainly changed, which is fantastic. And the recommendations on holistic care actually include a section on caregiver support and inclusion of caregivers in rehab, in psychological support, for example. So I think that is emerging. Caregivers are emerging as having their own unmet needs, which now need addressing as well.
Okay, thank you. Before to finish, I will ask each of you to share one closing remark. Nikki.
My closing remark is 3 words: awareness, awareness, awareness.
Okay. Okay, David.
Well, mine's not 3 words, but thank you. It's great to be here today with the cardiologists. It's fair to say they probably got a really big contribution with this, because quite often amyloidosis, a high proportion of them do have the heart element to it. So it's great to be here talking about it. And as Tirusha said, the ESC a few years ago had very little, and now I can't say it's 43 presentations going on. So that is a significant improvement, and that's what getting the cardiologist aware of it is going to be so important to take it, get it diagnosed at an earlier stage than we have now. So that's great.
Thank you. Tirusha.
3 words.
3 words? No chance. You know me, David. I think for me, it's really about that patient-centric care. So, not looking at labels or diagnoses, but rather at the person in front of you, and working with them to arrive at the best, not just the best medicinal treatment, but also the best care overall, broad care package that person needs to help them live well with amyloidosis.
Thank you. So thank you all for your engaging participation in today's session of cardiomyopathies, amyloid cardiomyopathy. And thank you again for your contributions. And I look forward to seeing our collective efforts make a meaningful difference in the lives of those affected by ATTR cardiomyopathy. Thank you for the soul of this session.
Thank you.